for the presenters. So do the radiation oncologists have any questions? Maybe for Dr. Nakayama in particular about the data?
So what was your typical protocol used for the felines with the oral squamous cell carcinoma? What was the most common protocol, radiation prescription?
の扁平肺がん放射線使ったプロトコル、放射線のプロトコル何でしたか？
And 6 gray, 6 fractions.
It was once per week?
Once a week.
Was that across your nasal tumors? When all the, because you have quite a few tumors that are nasal tumors treated, did you use the same protocol or are they different protocols?
Same protocol.
So are all the cases with SQAP 6x6?
Or 4x8?
There are 4x8 or 6x6?
Yes, yes.
Have you ever given SQAP daily with a compressed fractionation?
Unfortunately, I haven't have such experience. So,
other questions?
Yes, I have a question. Thank you for the very good presentation. It was very, very interesting cases and then beautiful pictures. You show the pictures side by side for the feline oral squamous cell carcinoma before and after the radiation therapy, the combination therapy of the radiation and SQAP. And then what is the timeline like between the pictures? When did you see those oral nasal fistula after the radiation therapy?
I think the oral nasal fistula happens quite early, like at the 3rd or 4th treatment. So now I'm against the excessive radiation on the feline squamous cell carcinoma. So it impairs the quality of life from the fistulas.
Yeah.
So
I think that's because seems like the drug worked too well, right?
too well.
Yeah. So I think there's a room because I'm curious, if we can use this drug for feline oral squam, which is a terrible disease. We all agree. I wonder if we can kill the cancer a little bit more slowly or like killing softly, right? Like a music, like giving smaller radiation dose, but more like a more fractionate kind of protocol. Then in conjunction with this drug, we know that this cancer can respond to radiation for some short period of time. I wonder if this drug can eventually prolong the duration of the disease control. But of course, this is not the main scope of this, our initial project. But in the near future, I'm curious if we can try this kind of thing.
Do you think, Hiroto, maybe that also may be an issue as well as with those larger fractions and the number of them over time, that maybe there is a late effect component to it? And so my question, I guess, for you guys is why do you think that the normal tissues aren't showing any more intense side effects like we would expect sometimes with a radiosensitizer?
We
don't know. So
we probably, I think
my question, the reason why I was asking what's the time frame between the picture was, is it possible that this drug may cause more significant late side effects, more likely, acute side effects as well? But is there any possible that the drug may cause those like non-healing, bone necrosis or something very scary, potentially life-threatening radiation side effects more than the placebo or just the radiation group, in your opinions?
I think that portion we don't know yet because
Okay.
those, Dr. Nakayama's photos or that particular case was only, even before finishing the radiation course, the
Right.
fissure happened. So yeah, I'm curious too,
Yeah.
the radiation dose intensity wise, the protocol was fairly more palliative intent protocol versus definitive intent. So we don't know if we use definitive intent protocol, we may see more significant, acute side effect or even late side effect. But that portion is, we can discover, we can investigate later, right?
So the alternate possibility is that there's a tumor intrinsic sensitizing effect that is specific to the cancer cells, and that the rapid death is almost like an SRT, where you're just killing everything off and then you're left with the whole,
Right.
which we
Right.
never see in oral squames.
No,
I mean,
yeah, we don't.
that to me was pretty profound. I've been through recently a very unpleasant clinical trial in cats with squame, and more often they just don't respond, or they respond minimally. But it's rare that we get them to respond and have, particularly during treatment, and have so much tumor death that there's essentially an oral nasal fistula.
So when
I
you
agree
guys,
with, sorry, go ahead.
sorry, when you guys think of about a more definitive intent protocol, and I always try in my practice more recently, not trying to make the protocol define the intent, but what do you think that protocol, that more fractionated protocol might look like? In my mind, just thinking with how bad oral squamous cell carcinoma is, the 4 gray times 5 fractions on a daily basis is one, something that we really do very commonly, especially I've done it in a lot of cats with oral squamous cell carcinoma. So we know about that, but it's also more of a fractionated protocol. And the fractions are obviously much, much smaller than a 6 gray fraction.
I personally feel in the future, if I construct a clinical study, like with feline oral squame with this drug, I was thinking probably like using like a truly fractionated protocol. We know that this cancer will come back very quickly after even definitive intent. So that means, that makes me feel we probably need a higher total dose. Like human head and neck cancer, they use like a 2 times 30 fraction, something like up to 60 gray or even higher. So I was thinking, of course, anesthesia for cats, more than 20 times would be definitely a challenging thing. But I know Cheryl is, no, please.
The last experience made me not want to do another clinical trial.
Well,
With cats,
yeah,
because they have so many problems.
I agree.
Yeah.
Adding your comment about the radiation responsiveness of feline oral squame, when I did SRT clinical trial at Colorado, they responded pretty well. I did single or 3 fraction, they responded pretty well. And then like his case, they ended up developing fistula or like a necrotic tongue. So we know that they can respond to radiation if that dose intensity is very high. But always the early tumor recurrence, that's the biggest, that's the biggest reason of treatment failure. So I'm hoping that by killing this tumor more slowly, but try to sensitize this tumor by using this drug, then again, like 20 or 25 fraction something, if we have a perfect candidate, that's what I want to try. But
Well, I mean, I think 3 gray times 20 in a cat. I mean, I certainly have done that before. It's doable in the right patient and with the right support team to do that.
Right owner too, yeah.
And the right owner.
Yeah.
Squame makes it very hard because they're not eating and drinking to begin with, and then supporting that patient through 20 fractions of radiation can be very challenging.
But it was interesting. The retreatment was really interesting. I found that really interesting. So you could envision a scenario where you could treat maybe the 4x5, get enough disease reduction that the cat's clinical status improved. And so
You put them into a clinical remission, but it's maybe not really like a true full remission.
So then you could retreat them if it started to grow back, but they would be healthier because they would be eating and drinking.
That's one of the main advantages I like about that 4 gray times 5 protocol is that it's always very difficult to predict in a palliative situation. How long is this patient going to live? That's the question that the owner always asks me and that I never have the best answer for. I can tell you about what happened to everybody else, but what's going to happen to Fluffy. And the thing that I like about that protocol 4 gray times 5 is that if they live longer than you expected, I have no problem repeating that protocol.
Okay. Does anybody else have questions from the group? Did we want to open it up to the panel, the people on the panel who may want to ask some questions on the people that are listening in? If you have a question, do you want to either raise your hand or type it into the chat? Do you see a randomized study with fractionated protocol on one specific pathology, VRTOG, any toxicity on a protracted daily administration? So I think that's what do you want to talk about what we talked about today? Do you want to lead that discussion?
Yeah, so I think that this morning we had a very productive discussion about what kind of clinical trial could we conduct for nasal tumors, because a lot of the data that you all have generated already in Japan is with nasal adenocarcinoma. And we were thinking of using the 4 gray times 5 fractionated protocol and then initiating a pilot study with that and then following those up at approximately 3 months with a CT scan to compare 2 groups of patients that have been treated with SQAP versus placebo.
And I think in those cases, the patients would get the SQAP daily. So they would get it every day for the 5 days of radiation. And we would be able to evaluate the toxicities to the normal tissues through the grading scheme of toxicities that's already established and would have CT scan measurements of tumor before and after at defined intervals, along with clinical chemistries and CBC to look for additional toxicities. So I think, and I'd like to hear from the rest of the people listening in today. One of the concerns we had in the US is that 6x6 treatment protocol is not something we typically use in the US. And so, and additionally, as was pointed out earlier, that if you are potentially causing sort of that sensitivity through enhanced oxygenation, that you would really actually benefit from that probably better in a 4x5 situation rather than allowing for potential regrowth in between the 6x6 treatments, because you're delaying everything by a week.
You know, there's with the 6 gray times 6, there's no reoxygenation between fractions. So by doing a daily fractionated protocol, you take advantage of that reoxygenation effect. And if the drug is working as a particularly potent hypoxic sensitizer, then the 4x5 is going to potentially be even more effective.
Thank you. Any other questions from the group? Do you know about the clearance, PK, as relates to daily administration? Would a different dose be needed compared to weekly? Do you want to talk about the animal safety studies?
Yes, so we conduct the argument study using rat and the dogs. The systemic exposure increases in dose-dependent manner. And so T-half is around 1 hour and a half, but on the dog, when administered at 4 milligram per kilogram. And there are no program regarding PK profile in dog.
And I think you did I think it was weekly, they got daily for, was it 14 days or?
Yeah, no drug accumulation
Yeah.
was noted in the repeated dose.
Right, so
ウィークリー、週1回か、
一回週一回
なんか4グレードのやつもありましたね。8グレード、4グレード。
they have done
Sorry.
safety studies where they've given it daily for a couple of weeks. And I think the dosing started at 8 mgs per kg, or was it 4? I can't remember which one you.
8 and 60
So-
and 30.
Yeah,
32
so
milligram.
there were, at the higher doses, there were some toxicities, but there was minimal at 8 and the dose that's being used is 4. So that's been done. And so they've had it daily for over 2 weeks and it really was pretty safe at the 8 mg per kg dose, but the 4 mg per kg dose is what's really being used clinically. So I think we're well within the safety window. But however, we don't know what the toxicity would be like if it was combined with radiation, although we'd be using a lower dose per fraction, so presumably it'll still be pretty safe. The next question is, can you talk briefly about stability of the drug? Can it be shipped and stored relatively easily? I can actually answer that one. So that the drug comes lyophilized, and so it's very easy to make up. You just add sterile water to it. It already has saline, sodium, and chloride in it. So when you make it, it then becomes isotonic, essentially. So the drug is stable at room temperature for several hours. And so it's very easy. You just add the water and you let it dissolve, and sometimes there's a little bit of bubbling, and then it's ready to go. But we usually leave it out at room temperature after it's been reconstituted for a little bit and then draw it up and use it. It's not a carcinogen or a teratogen, and so you don't need to use any sort of anything like EquiShield or one of the self-contained administration apparatus like you would with a chemotherapeutic, and you don't need to draw it up under a hood necessarily either. So it's very easy to give. The one thing I would add is that we've been giving it very slowly, so we tend to give it over 15 to 20 minutes, just to avoid any of the potential cardiac effects as well, and also to make sure that we don't have any irritation of the blood vessel. Other questions? Okay, so do you want, yeah, we can show the slide here of the preparation. So this is what it looks like when you get it, is it's lyophilized. And then, can you go back, please, one slide? So you can see that you add the water, and then it becomes this brown solution that then clears up, and it's very easy to administer. So it's a clear solution, even though it initially looks very bubbly. You store it at room temperature, and you can heat it up a bit if you need to get it into solution, but we actually haven't had that issue at all.
匂いとかないですか？海の匂いしないですか？ I was asking him, it smells like some sea urchin or sushi. The answer was no.
Okay, next slide. So we've been infusing it. I know you'd mentioned that you give it over 2 to 5 minutes, but we give it over 20 minutes, basically. And you can give it over 15 to 30 minutes, but we've been giving like between 15 to 20 minutes. For most of the dogs, we're using a syringe pump because some of the smaller dogs need a very small volume, and it's hard to control the infusion when it's a small volume. And then really we end the administration, and then the patient would go get anesthetized and get it set up for radiation. And generally that you want to make sure that they get radiated within 15 to 30 minutes of ending the administration of the drug. The drug is an irritant, so you definitely don't want to extravasate it. We treat it like a doxorubicin or Tenovia injection, where we make sure we have a clean stick catheter and we're monitoring the infusion at the whole time, so we never leave the dog unattended. And we haven't had any issues with respect to irritation or pain at the site of administration. I think at least some of that is if you push it too hard. I think for those of you that use Serenio and you give it IV, some of the dogs react to it. And if you give it really slowly, then they're less likely to. So we have not seen any evidence of irritation or pain. And we haven't seen any issues with essentially cardiac issues, because we are giving it slowly as well. So I think if you just are careful to give it over 20 minutes, you should not really have any problems.